today we are going to see about the chronic cough in children. So respiratory diseases are the common cause of hospital admissions in children. So respiratory disease responsible for significant school absence in children. Cough is one of the most common mode of presentations. The epidemiological studies suggest the prevalence of cough range from 2.5% to 18% with a significant impact on quality of life. So this indicates how common the cough in the community. Cough occurs through a stimulation of a complex reflex arch. The stimuli can be an irritation of the cough receptors by chemical or mechanical stimuli. The stimuli are carried by the afferents, which are type C and type I fibers, which are located in the pharynx, larynx, large airways, terminal bronchioles, and the lung parenchyma. In addition to these receptors are also arises from ear, heart, pericardium, diaphragm, stomach, and esophagus. So when we evaluating a cough, the cough may be not only from the respiratory system, the origin may be from the other than the respiratory system. So we have to consider this as a cause. The afferents travels mainly via the vagus nerve, and the cough center is located in the medulla, the nucleus tractus solitarius. The efferent nerves travel through the vagus to the larynx, trachea, and the bronchi, and the pharynx to the diaphragm, and the spinal motor nerve to the expiratory muscles, including the pelvic sphincter. So this diaphragm gives a summary of the cough reflex. The location of the cough receptors are in the larynx, supralaryngeal area, trachea and the bronchi, ear canal and the eardrums, pleura, pericardium and the diaphragm, esophagus and the stomach, and the afferent travels to the vagus, and the cough center is in the medulla, and it also gets the control from the CNS cortical modulation, and then efferents travels to the spinal motor, pharynx and the vagus to the diaphragm, larynx and the expiratory muscles. A study done in which a cough was measured objectively found that healthy children of mean age of 10 years have an average of 10 cough episodes per 24 hours. Mostly healthy children, they usually get a 10 per day. And this number increases during the respiratory infection. And a healthy child can get 5 to 8 respiratory infections per year. And these infections range for 7 to 9 days. So this will cause an additional cough during another 50 days per year. It is likely that the younger children will have more infections than the older ones. So this indicates how common the cough is in children. So now we will see about the chronic cough. Chronic cough is defined in children as a daily cough for more than 3 to 4 weeks. When cough lasts less than 2 weeks, it is an acute cough, and when it lasts for 2 to 4 weeks, it is a subacute cough. The extensive morbidity from chronic cough has been documented in a study of 190 children referred to a tertiary care center in Brisbane, Australia, where more than 80% already had 5 unsuccessful physician visits for the cough, and 53% had 10 such visits. So this indicates how the morbidity is affecting a chronic cough in children. The median age of these children is 2.6 years, and the symptoms substantially impacted sleep and the school attendance. Study by subjective impression of parents reveal 10% of preschool and early school age children have chronic cough without these at some times. So this is indicate how common the chronic cough in pediatric populations. Parental smoking is associated with an increased prevalence of chronic cough, and a study shows that children below 11 years with both parents are smoking, 50% had chronic cough. Another study identified 22% of children of preschool age reported a chronic cough without cold, and this cough has persisted several years in more than 1/3. And children with chronic cough were not more likely to develop asthma and atopy than the normal population. So this indicates there is no hyper airway responsiveness. They had normal lung functions and airway responsiveness are normal. And this indicates they may have temporarily increased cough receptor sensitivity, which returns to normal when the cough is settled. So now we'll see the causes of chronic cough. So chronic cough can be divided into non-specific cause or specific cause. So non-specific causes where there are no symptoms or signs to suggest a specific cause. Specific cause, in specific cause, there are other symptoms and signs are present and which points to a specific cause. So under the non-specific causes, we can think about the post-infectious causes, mycoplasma or habitual cough. In specific cause, the asthma, bronchiectasis and gastroesophageal reflux disease and so on we can go. So now we will see about the causes of recurrent or persistent cough in children. When we think about the recurrent cough, the common ones we can think about this asthma, the airway hyperresponsiveness, and drainage from the upper airway, the postnasal drips, the aspiration syndrome, and frequently recurring respiratory tract infections. The persistent cough can be a reactive airway disease, the cough variant asthma, a chronic sinusitis, bronchiectasis, cystic fibrosis, gastroesophageal reflux disease, endobronchial infections like tuberculosis, habit cough, chronic allergic rhinitis, hypersensitivity of the cough receptor after an infection, foreign body aspiration, recurrent microaspiration, infections like pertussis or mycoplasma atypical infections, extrinsic compressions like a vascular ring or lymph nodes, endobronchial endotracheal tumors, or a fungal infections. The list goes as a long list. But when we think about the differential diagnosis of a chronic cough, the isolated chronic cough with otherwise healthy child, we have to think about if the child is a small infant or a toddler, the common one is the recurrent viral bronchiolitis. And if it is a bigger one, we can think about the cough variant asthma. The other causes are post-infectious cough or pertussis like illness, postnasal drips, psychogenic cough, and the gastroesophageal reflux. So most of the time, we may encounter kids with the isolated cough, otherwise they are healthy. So we will see in detail about the isolated cough with otherwise healthy children. So when we consider the infection, simple recurrent viral bronchitis is very common in children. They manifest with bouts of coughing associated with bronchitis occurring concomitantly with the viral upper respiratory tract infection. These children will experience short breaks in the symptoms in between the infections. These infections are commonly seen in crowded places and exposure to tobacco smoke. So as this is a repeated infection, when we take the history, we have to ask whether these 4 weeks of symptoms is a continuous symptoms or whether the kids are well in between a short breaks. So this will help us to differentiate whether it is a recurrent infection. Pertussis syndrome. So it is also known as a 100-day cough due to its chronic nature. Pertussis, the cough is harsh, non-productive, spasmodic, and choking in nature. It may result in classical whoop or vomiting. Even though it's treated with macrolides, it may eliminate the infectiousness but not alter the clinical course. With the immunization, the pertussis is less, but the pertussis-like illness is caused by adenovirus, mycoplasma, and chlamydia, and where we may not see the classical whoop. The other common one is the persistent bacterial bronchitis. So it's commonly seen in young children, mainly during the first year of the life. So they present with the chronic wet cough. Here it is not a dry cough, they present with a wet cough. Expectation of spontaneous cessation of symptoms, absence of fever, and generally normal growth and development are the reasons for the delay in referral of these patients. So the confirmation of persistent bacterial bronchitis requires a bronchoscopy with the bronchoalveolar lavage. The bronchoscopy will show a dynamic collapse of the trachea, and the bronchoalveolar lavage will show a high colony count of potentially pathogenic bacteria, where we can get more than 10 to the power 4 colony forming units per ml of pathogenic bacteria. The common organisms isolated are same as found in the otitis media, such as Streptococcus pneumoniae, Haemophilus influenza, and Moraxella. It can be successfully treated with oral amoxicillin clavulanate for at least 2 weeks. Other antibiotics are second or third generation cephalosporin. Sometimes prolonged courses like 4 to 6 weeks of antibiotic is needed, along with intensive physiotherapy before the infection is eradicated. So when an infant presenting with the chronic cough, we can think about this. Post-infectious or post-viral, it refers to the presence of cough after an acute viral respiratory infection. Most of this cough resolves naturally, but over a long period. The usual respiratory tract infection settles within 2 weeks, but here it takes more than 2 weeks over a prolonged period. It's usually not respond to any available treatment like a normal treatment of cough. They may have an increased cough receptor sensitivity. Because of increased cough receptor sensitivity, they have the infection of post-infectious cough has prolonged period of cough. When a child presenting with a prolonged cough, like infections like tuberculosis, we have to think and exclude. The other common one is the psychogenic cough. The psychogenic cough can be defined as chronic dry cough without evidence of underlying illness. It may present as thick dry cough, a dry, repetitive, and purposeless cough that persists after a simple upper respiratory infection, can be loud, harsh, barking sound described as barking, or it can present as bizarre conky cough. The child is indifferent to the cough, but the parents are usually extremely worried. So unique to the psychogenic cough is the cough disappears at the night during the sleep. After the child is going to the sleep, there won't be any cough episodes at all. The cough abates when the child is engrossed in the activity and more noticeable with attention. Characteristically, these children are older, more than 5 years, and they are bright students and they are eager to be pleased. The other one we have to think when a child who presents with a bell and the chronic cough, the cough variant asthma. The cough variant asthma is diagnosed in a child with persistent, isolated, non-specific cough who has one or more of the following: the airway hyperresponsiveness, airway eosinophilic inflammation, atopy, whose cough responds rapidly to anti-asthma medication. So cough without wheeze has a more favorable prognosis than cough with recurrent wheeze in preschool children. It tends to resolve before the age of 6 in most cases. A survey done in US in school-age children with asthma identified that both cough and wheeze were present in 85% and cough as the sole symptoms in 6%. So this 6% will not have a wheeze at all, and they will have only the cough as a symptoms. The presence of airway hyperresponsiveness was not associated with the response to the anti-asthma treatment in children with persistent recurrent cough. So this suggests presence of bronchodilator responsiveness is not a very helpful tool for the diagnosis of cough variant asthma responsive to anti-asthma treatment. These children will not much readily respond to the bronchodilator treatment. So the first stem as hyperresponsiveness or treatment to the asthma, anti-asthma treatment cannot be treated with the bronchodilator responsiveness. A study done in bronchoalveolar lavage in children with cough variant asthma, only 10% had the increased eosinophilia. Only minority had true if asthma is defined as airway eosinophilic inflammation. One of the definition is airway hypereosinophilia, but the cough variant asthma, the studies have shown only 10% has the increased eosinophilia in the bronchoalveolar lavage. So the most efficient and effective diagnostic test to identify chronic cough as a manifestation of asthma is a short course of oral corticosteroids. So if they are responding to the corticosteroids, then it's suggestive of a cough variant asthma. The other cause is the reflux and the aspiration. Reflux with or without aspiration of gastric contents of food is one of the most common cause of chronic respiratory symptoms. Both the microaspiration and the vagal reflexes can contribute for the cough in these children. A study done to analyze the etiology of the non-specific chronic cough in children of 5 years and younger identified upper airway cough syndrome like postnasal drips as the common cause. It's nearly 37.6% has an upper airway cough syndrome. Other causes are cough variant asthma, which comes as the second common, nearly 1/3 has a cough variant asthma. And then it goes as a post-infectious gastroesophageal reflux and allergic cough. And there is nearly 5% had unknown etiology. When a child presenting with the chronic cough, the serious lung pathology should be considered when the cough originating from the neonatal onset. So if a child gets this cough from the neonatal onset, we have to think about congenital defect or problem with the ciliary functions and infection like cystic fibrosis or primary ciliary abnormalities, anatypical lesions of the airway like cyst or tracheomalacia, or chronic viral pneumonia like a cytomegalovirus infection. And when these kids are having chronic moist or purulent cough, we have to think about some serious lung pathology. When the cough started and persisted after choking episodes, we have to think about foreign body. And when cough occurs during or after feeding, we have to think about gastroesophageal reflux disease and aspiration. And when these kids are ill and having clubbing and crepitation or auscultation, we have to think about chronic suppurative lung disease. So we will see about few specific causes of chronic cough. The cystic fibrosis, as you all know, it is an autosomal recessive disorder, mostly diagnosed in infants and toddlers who present with either or both of the following: recurrent cough or chest infection in 50%, which is the common form, and failure to thrive despite a good intake, 30%. So over 90% of children with cystic fibrosis have malabsorption and steatorrhea due to pancreatic exocrine enzyme insufficiency. 10% can present in the neonatal period with meconium ileus. Around 15% may have an adequate pancreatic function and may not be diagnosed until later in childhood. So these children may present only with the chronic cough, and we have to think about these children when they're presenting only with the chronic cough. Should be considered when asthma is not under control. So when we are treating for the asthma, when it is not under the control, we have to think about whether it is possible for the cystic fibrosis. Sinusitis, often associated with recurrent nasal polyps, may be seen in these children. The non-bacterial infections are Staphylococcus, Haemophilus influenza, Pseudomonas, and atypical mycobacteria. So when these kids getting these infections, we have to think about whether it is a possible cause for the cystic fibrosis. Bronchial hyperactivity with wheeze and evidence of reversible airway obstructions are common. They can get allergic bronchopulmonary aspergillosis. Minor hemoptysis is common. Progressive decline in lung functions leading to the respiratory failure and development of copulmonale is seen in children with cystic fibrosis. They have increased incidence of celiac disease and Crohn's disease. They can get growth failure and delayed puberty, and diabetes mellitus and liver cirrhosis. The second cause of a specific cause of chronic cough is a primary ciliary dyskinesia. It's a congenital abnormality of the ciliary function, impair the mucociliary clearance of the airways, and leads to the chronic respiratory symptoms, including chronic cough. It's a heterogeneous recessive disorder. So more than 80% will have a transient neonatal respiratory distress. So when a child presenting with the chronic cough and the history suggests they had a transient neonatal respiratory distress, it is suggestive. We have to think about whether it is a possibility of primary ciliary dyskinesia. It should be suspected in children with combination of unusually severe ear, nose, throat infection and the lower airway infection. So both the upper and the lower airway infection they can get. Chronic cough and recurrent ear infections begins in infancy. They present with chronic wet cough. They present with the wet cough rather than like cough variant asthma. They present with the dry cough. May have a situs inversus totasis, a complete reversal of the internal organs. So that points towards this ciliary dyskinesia. They can have a normal growth and development, and progression of chronic lung disease is much slower than the cystic fibrosis. Even though they progress as chronic lung disease, the progress is slower when compared to the cystic fibrosis. Pathogenic bacteria are not common in primary ciliary dyskinesia, but it is common in cystic fibrosis. They may have chronic otitis media and male infertility, which can develop later. The other possible cause is the congenital anatomical abnormality. The anatomical abnormalities may cause chronic cough. The tracheomalacia, where the dynamic collapse of the trachea can cause chronic cough. It is stimulated by anterior and posterior surfaces of a portion of the collapsing trachea, making repeated contact. Cough is often barking in quality, similar to the croup. Tracheobronchomalacia may be isolated or it may be a part of the syndrome. So we have to think about when they are presenting with the chronic cough, like a barking cough. Tracheoesophageal fistula or laryngeal cleft can cause chronic cough due to the aspiration, especially during the meal. Vascular malformations like coarctation of aorta and pulmonary sling causes seal-like barking cough, which is severe with viral upper respiratory tract infection. Pulmonary aspirations. Foreign body aspirations can result in retention for months, but presenting as chronic cough is rare. Should present as a recurrent bacterial pneumonia, lobar or lobular hyperinflation, and atelectasis. Bronchiectasis can occur from a long-term retention. The study has identified mean interval of 55 days until a bronchoscopic extraction was reported. It is common in under 4 years old. World Allergy Organization, Allergic Rhinitis and its Impact on Asthma, Joint Committee on Chronic Cough reviewed the current literature on classification, epidemiology, presenting feature and mechanistic pathway of chronic cough, and they classified chronic cough into upper airway cough syndrome, laryngeal hyperresponsiveness, gastroesophageal reflux disease, lower airway cough syndrome, and the others. Under others, we can think about the obstructive sleep apnea, psychological, and COVID-19. Based on the clinical models, it is speculated that the underlying mechanism of chronic cough is a neurogenic inflammation of the cough reflex, which become hypersensitive cough reflex, which is causing the chronic cough without any specific causes. Respiratory infection can induce a hypersensitive cough reflex without the airway hyperresponsiveness. There won't be any airway hyperresponsiveness, but the cough reflexes is hypersensitive. So now we will see about the assessment of children with the chronic cough. First, we have to establish the presence of chronic cough. So it is lasting more than 4 weeks. And then assess the cough quality. Look for the classical characteristic. It may suggest the cause of the cough. If the barking cough, we can think about tracheomalacia and habit cough. Honky cough suggests it's a psychogenic. Paroxysmal cough, think about the pertussis or pertussis-like syndrome. Staccato cough is a chlamydial infection in infants, and the wet cough, it can be a protracted bacterial bronchitis if it is an infant, and if it's a bronchiectasis in a bigger child. We have to look for any red flag signs the child is acutely ill, tachypnic or dyspneic, and then we can look for the detailed history to identify the cough pointers. So the pointing towards a systemic etiology. So the cough may be a part of a systemic disease. Then the child will have a failure to thrive, feeding difficulties, fever, clubbing, neurodevelopmental delay, or cardiac abnormalities. These features will point this cough is from a systemic pathology, not from the pulmonary origin. A child who is having wheezing, hemoptysis, daily moist productive cough, positive auscultatory finding, chest fold deformity, these features will point towards a pulmonary etiology. So we can, after history and examination, we can identify whether this cough is from a systemic etiology or is it from a pulmonary etiology. So in the history, we have to assess the severity and time course of the cough, special features including diurnal variability, fever, relations with meal and possible foreign body aspiration, habitual vomiting, production of the sputum. So ask about the onset, duration, characters, trigger factors, variation with the time and the posture, which suggests the postnasal drip and aspiration, sputum, the amount, color, whether it is blood stained or not, and the past history of asthma or wheeze, history of atopy and eczema, which favor the cough variant asthma, symptoms suggestive of gastroesophageal reflux disease, rhinitis, postnasal drip, throat clearing, and nasal condition, and sinusitis, which favors the upper airway cough syndrome. And conduct history of TB, we have to always ask about. And history of foreign body, a choking episode, the cough started after a choking episode will favor a history of foreign body aspiration. And finally, we have to ask whether it is a recurrent infection, whether the child is well in between or whether it is continuous cough, to see whether it is a one infection or one syndrome. In the examination, we have to look about the growth and evidence of atopy and the VCG, upper airway, clear examination of the upper airway, and look for the signs of clubbing and detailed respiratory examination. After history and examination, if the cough absents one sleep, it favors the diagnosis of habit cough. If cough lasting more than 3 months and spasmodic, it favors the diagnosis of pertussis. Cough starting in infants with feeding, we have to go for a swallowing study suggestive of some aspiration. Cough since neonatal period, history of transient tachypnea of newborn, and chronic otitis media, we have to think about the primary ciliary dyskinesia. And cessation of cough after a short course of steroid, we can think about cough variant asthma. If the chest X-ray suggests a lobar hyperinflation, we have to think about foreign body, which is lasting for some time. And if the chest X-ray suggests situs inversus, we can think about primary ciliary dyskinesia. Flexible bronchoscopy and bronchoalveolar lavage may diagnose tracheobronchomalacia and protracted bacterial bronchiolitis. So, after the history and examination, if there is no specific clues for the cough, then all the children should undergo a chest X-ray. And after chest X-ray, if the chest X-ray is normal, if the child is more than 2 years, we can go for the allergic testing, and we have to look up for the ENT checkup for the upper airway part. And then if the child is more than 5 years, we can go for the pulmonary function test to diagnose cough variant asthma. And if everything is normal and still the cough is persisting, if the child is less than 2 years, we can think about reflux studies and the sweat test. If anything, we think about abnormal, then we can go for a specific test. If there's a clues for the specific pathology, then we can go for a specific test. If we think about ciliary dyskinesia, we can do a ciliary function test. If we think about cystic fibrosis, go for a sweat test. And if there's a foreign body suspicious, the bronchoscopy, And if the child is having purulent infection, we have to take sputum culture, bronchoalveolar lavage culture, CT, immunology, and the sweat test to diagnose bronchiectasis. If there is reflux aspirations, we have to do barium swallow, 24-hour pH recording. And if suspicious of pertussis, we can go for serology. And if thinking about congenital anomalies, we have to go for the bronchoscopy, CTO, MRI, and angiography if we are thinking about some vascular risks. So this is a summary of the investigations. After history and examination, if there is no specific clues, chest X-ray, allergic testing, ENT, and pulmonary function, if everything is normal and child is less than 2 years, reflux studies and the sweat test. If abnormal, specific tests we can go for. If there is a specific clues for the specific pathology, we can do the test, ciliary dyskinesia, cystic fibrosis, foreign body, and reflux, we can go for the specific test. So now we will think about management of chronic cough. If specific cause is identified, manage the specific conditions accordingly. So trial of treatment of most likely cause should be considered if there are no pointers. If there is specific cause like a cystic fibrosis or primary ciliary dyskinesia, that is mainly the pulmonologist site management, and we all know how to manage bronchiectasis and all the things. The main problem is there is no specific cause, so what to do and how to manage, that is our main problem. So trial of treatment of most likely cause should be considered if there is no pointer. So what we think after a history examination and the investigations like a chest X-ray, so what is the most likely, and then we can manage the most likely pointing one. So management of otherwise well child with persistent dry non-productive cough will include reassurance and watchful anticipation, and remove the exposure to a cigarette smoke. So always in all the children, the precipitating one or aggravating factors like smoke exposure should be removed. And if the patients are understandable, we can reassure and we can watchful anticipation. It will improve in times. We can wait. So several epidemiological studies have shown that chronic isolated non-specific cough improves with time without any treatment. So the several studies if the child is well, only having a chronic cough, otherwise well, and chest X-ray is normal. Non-specific chronic cough resolves spontaneously, but children should be re-evaluated for the emergence of specific pointers. So we can't say your child will improve, you can go, but the child may develop some pointers pointing for some chronic lung pathology or some serious illness. So all the children with the chronic cough, we are reassuring, should be re-evaluated to make sure that the cough has settled, or to examine and see whether they are developing any specific symptoms or signs which is pointing to a specific cause. And till they improve, they have to be followed and re-evaluated. So this over-the-counter cough medications like use of codeine and dextromethorphan has no benefit in chronic cough. So there is no point in giving these drugs to the kids, which will have only the side effects, but it is not going to improve the children's cough. Long-term inhaled corticosteroid has no benefit. So no point in giving this long-term inhaled corticosteroids. Antihistamines. The efficacy of antihistamines agents in relieving chronic cough in children is minimal. Studies have shown there is no beneficial in giving antihistamines. There is no place for the mucolytic agents. Antitussives sometimes may be helpful, but it should not be given as the first line, as they may retard the proper diagnosis. But if the children with non-specific cough, and there's a risk factor for the asthma. So if we are thinking that it may be a possible cause for the cough variant asthma, we can try a short trial of steroids, and all the kids should be, when we are giving a trial of steroid, they have to be re-evaluated in 2 to 4 weeks times to see whether they have responded. And if there is no response, it should be discontinued immediately. Antibiotic, the appropriate antibiotic may be needed if there is an established or suspected infection, mainly if we are thinking about persistent bacterial bronchitis, so it may need a prolonged course of antibiotics. So if we are thinking an infant who is presenting with the wet cough, prolonged and protected bacterial bronchitis, we can try a prolonged course of antibiotic. So if there is suggestive of a reflux, we can manage the reflux. And if there is allergic airway disease, we can think and manage that causes. So this is a summary of the management. If there is a specific cause, we can manage the specific cause accordingly. If there is no specific causes, watchful observation, avoid the smoking, and think after chest X-ray, pulmonary function test. If the history is suggestive of a dry cough, we can trial of the corticosteroid. If it is a wet cough, we can think about antibiotic, and all the kids should be followed up to see whether they have responded. So now we will see the last part, the complications of chronic cough. So even though it is non-specific chronic cough, it will resolve spontaneously. It can cause some complication. It may induce the bronchospasm. It can cause even the trip fracture. It may lead to the air leak like pneumothorax and pneumomediastinum. Even it can show that it can pull the intercostal or rectus abdominis muscles. So even though it will settle on its own, there are some complications of this chronic cough. So final, the take-home message of my chronic cough in children is the chronic cough is common in children. The isolated cough with otherwise healthy child is mainly due to the upper airway cough syndrome, recurrent viral bronchiolitis, or cough variant asthma. Underlying mechanism of chronic cough is the neurogenic inflammation of the cough reflex, which become hypersensitive cough reflex. The chronic isolated non-specific cough improves with time without any treatment, but always need re-evaluation to make sure the cough has improved or there is no pointers for a specific disease.